Thank you. Thank you very much. Excellent presentation. And we had a long day, but we still have some time, for questions. So if anyone has questions, please. Dr. Muhammad, you should join us here because you were a part of this. Okay.
Thank you very much. I just want to make a comment. Thanks for Professor Yusuf. Great compromise and sort of balance to come to this consensus to reality. At the end of the day, in the perception of the vast majority of people, and indeed physicians, a person with advanced kidney problem is a very ill person. It just doesn't have to, and the Quran says, "Man kana maridan." So if a person with advanced kidney problem, who are the vast majority of them have comorbidities, is not ill enough to be advised not to fast, then I just wonder who is ill. So I'm delighted that we've managed to come to this reasonable consensus until we have further data to tell us that it is safe. Because a major point is, the data that we have is biased data. The data is about the people who fasted. And we forget that from our data, 45% of people with type 1 diabetes and CKD do not fast. 25% of people with type 2 diabetes and CKD do not fast. So it's already, before we start, it's biased data because of looking into those who fasted. That's one. Second, the vast majority of these studies are in countries of high income, where the facilities are there, the ability to bring the person 1 week and 3 months and 2 weeks before Ramadan and during Ramadan is there. The reality in so many countries, that is impossible. To have dialysis on its own is an achievement, let alone to have this. So I think we need to put aside our sort of passion about Ramadan and just think pure science.
Yeah, good point. You stole so many questions of ours.
Can I just make a comment?
Sure.
Thank you very much, Professor Muhammad. Just to concur this, in fact, our religion is Deen Yusr. And in the same verse of Quran, after the mention about that those who are sick could fast after in other days, the Quran mentioned يريد الله بكم اليسر ولا يريد بكم العسر. Fasting Ramadan, Allah Azza wa Jal didn't intend for Muslim to have make life difficult. And in fact, we have to remember, not only if the fasting can cause a little bit worsening of the kidney of the disease, a patient is allowed to break fasting. But also if it has no effect on, for example, we are talking about kidney disease. If the fasting has no effect at all on the fasting, but fasting a little bit harder on them, the Islamic scholar, they said he is allowed to not fast, mashaqqa. And one of very famous Islamic scholar, he said how to measure the mashaqqa. If this patient fasting, he is feeling more, even slightly harder than if he is not sick, it's allowed that he's breaking fast. The other point, and very important, we tell this patient, because our patient, when we say that moderate risk or high risk, it doesn't mean that we advise them to fast, but we tell them that they have for moderate, for example, they have the permission to not fast, and it's better to not fast. And sometimes we tell them it is even makruh because there is a considerable risk, and some of them can go up to forbidden to fast. But we tell them if they don't fast because they have disease, the thawab will not be less, and as if they fast. So I think we have to use this not feel that if we tell the patient to not fast, we feel that we are guilty. No, it is rukhsa in certain, in many of these patients, that it's better to use it. إن الله يحب أن يؤتى رخصه كما تؤتى عزائمه. And in certain cases, it could be go up to forbidden.
Okay, thank you very much. Dr. Ala, how would your findings from your review affect your counseling with your patient?
With regard to microalbuminuria, I'd still say the data is not conclusive enough to change our recommendation or to change the risk stratification. We need to go further in studies and find out, is it just the microalbuminuria alone or the associated risk factors that increase the risk of hypoglycemia and hyperglycemia? So until we get better evidence, probably my practice is not going to change much.
Good. Thank you.
In the same line, have you noticed that increase actually microalbuminuria to frank albuminuria in patient, or no, we did not notice?
This part of the evaluation, when I tried to answer the two questions, we didn't find any data, not a single study that looked at the impact of Ramadan on microalbuminuria. But the only data that was done was on microalbuminuria, whether it's associated with increased risk or not.
Dr. Youssef, how would you plan to incorporate new data from the two studies? And you could answer the first question. But these two studies from Dr. Bashir and Dr. Ahmadani, how are you planning to incorporate these into your classifications?
Now, for proteinuria, whether it's albuminuria or mild albuminuria or overt proteinuria, we believe that it might be risk factors, but we don't have solid data. We have unpublished data that we hope you are part of this study done in the outpatient centers, which the regression analysis showed some increases in the risk when we go to stage 1, which is by definition stage 1 because normal GFR with proteinuria. So we feel that it might be a risk factor. We hope that we will be able to finalize the study. And now we put proteinuria as a risk factor for moderate risk patient. In our analysis, in our recommendation, Dr. Bashar, we try to review the literature mainly not assigned for studies for diabetic patient with CKD, pure diabetic, because this part you did it with DAR already, and we decide to complete the part that not studied by DAR, where we have kidney disease, not necessarily diabetic. And I think this is very important studies that we need more clear, good quality of studies where we support our recommendation. We took the safest way, as Dr. Muhammad mentioned. When we have not clear, so we took the worst of scenario, so it will be safer the patient with our recommendation.
Yeah, thank you. Dr. Ahmadani, why do we have conflicting results from different studies? I mean, safe, not safe, it's really confusing for practitioners. So could you comment on this?
I think
Dr. Ahmed answered a little, but I mean, I want to...
I think we need a lot of studies because we don't have prospective studies. We have retrospective studies and non-interventional studies. So that's why from retrospective studies, you cannot take out much because there are confounding factors, and unless you remove those confounding factors by looking into logistic regression analysis, only then you can say that this is a risk or not. Of course, the assumption is that there will be a risk, and studies have shown, the observational studies have shown clearly in larger numbers that those people who have a higher grade of staging of CKD, they have problems. We have seen in different surveys, so it's from those surveys, but we can plan prospective studies and see what happens.
Last question, maybe. Any question here? Do you really think that resources are the most important factor in safety of fasting? This is for everyone here. The availability of resources, whatever, I mean.
I think, yes, it is very important factor, especially if you mean by that the lifestyle, if you are your profession and social condition. This is what I understand you mean.
I mean availability of glucose monitoring, labs, hospital, good admissions, good ER, and so on.
Definitely,
Yeah.
definitely. But we have resources, patient side, and resources, healthcare provider. You cannot, patient will be, risk factor will change dramatically between somebody who is sitting in office, air-conditioned, taking his car, air-conditioned, going to home where everything is okay, compared with somebody who's working outside for 1 hour, even 2 hours. Then it is big difference. If they are CKD, it is a major difference. And also, if this patient has no access to care health, for example, or he is in remote area, then major problem could happen, and he might go into complete renal shutdown, and he doesn't know, or severe glucose hyperglycemia or hypo, and he doesn't know. So I think resource is very important, and this should be taken in consideration, as Professor Muhammad mentioned. Not whatever is done in certain area, it might not be applicable in different area, and this is what we do with all recommendation. When we have guidelines or recommendation, it is general recommendation, and you should be cautious when you apply in specific patient.
Absolutely. Thank you. Anyone wants to make any comment on this?
Dr. Effendi?
Dr. Ahmed?
Yes, yes.
Yes,
Can I
Dr.
just
Ahmed,
make
yes,
a-
sorry.
And I think if you look at all the studies were mentioned today, all of them were based on data from the side of physician. What about the data from the side of the patients? Well, I'm looking for qualitative research. We have to really study the patient's experiences. Patients with diabetes or kidney disease, how they experience the Ramadan fasting from their perspective and the caregiver also perspective. This is not, I didn't see any study. We talk about numbers, diabetes, sugar, A1C, creatinine, all this. This is from our side. Well, as for their side, that's really lacking. We need to also focus on that side. Because as we saw in the previous studies, we tell patients not to fast. They still fast. We need to understand those factors, why they insisted to fast, and what's their safety net they have, what their backup plan they already have. A lot of times we do not know those details. So I think this is one area needs to be also looked after in the studies.
Absolutely. We reported that 78% of our high-risk patients do fast against medical advice. Dr. Ala, you wanted to make a comment?
I really wanted to comment on the resources, and I completely agree that resources are really essential for safe fasting, but in areas with limited resources, I guess patient education is the key for safe fasting during the month of Ramadan.
I think I want to say this because poor can afford education. In fact, if 40% of the people have not received education, so education is affordable. Every poor, every rich, with the sources, without sources, education is, I think, compulsory, and each patient can receive education.
Absolutely. Thank you very much. You have any comment or anything? Any question here in the group? So thank you very much. This was an excellent session. Thank you all, Dr. Tarakji, Dr. Boubis, Dr. Ahmadani, and Dr. Bashir. Thank you very much. And I'd like to thank the audience. What? Yeah, okay. Okay. And now we'll move to the last session, which is the summary of the activity today. Thank you.